Shot. All right. Good morning. I'm Dr. Duke Majan. Shot. We are here at the Duke Spine Institute. Shot. That X is right over where I'm looking, Monica. Shot. Come on. And shot. Monica, the X is right over. Give me an AP, please. Honestly. Hurry up, I need the AP. It is now June 29th, 2023, and we are performing the Duke laser disc repair. That looks pretty good. On a patient with 3 herniated, degenerated discs. Shot. In her cervical spine. Shot. Why is the image so... All right, that looks okay. Shot. All right, let's get an AP. Coker. Relax, everybody. Sorry, folks. I'm having to focus here, and I can't talk too much, but basically, this patient has 3 bad discs, 1 herniated, 2 degenerated, with symptoms. You got to get rid of the X, okay? It is literally right where I have to see. We'll figure it out, Monica. All right, we're going to start at C5-6, then we're going to go to C6-7, and then we're going to go to C4-5. And on the AP view, we're in the midline, which is perfect. On the lateral, I need inline traction, please. On the lateral view, no, don't pull yet till the anesthesiologist has the head stabilized. Let's go. Got to get the show on the road. Shot. All right. Come on, Monica. It's ridiculous that your X is exactly where I need to be looking. Never had that problem before. Yeah, but it's your job to see things and fix them when it comes to the X-ray. So figure it out. Shot. All right. Good. Now, we're going to do a discogram. Sweating bullets, Louise? I'm the one who's supposed to be sweating bullets, not you. What a beautiful dye we have. Back to blue. Shot. Shot. All right. So we've injected some Omnipaque dye, which is a radio-dense dye, so I can see the tear in the back of the disc. I can see the herniation. And also it has some blue in it, which is called the Duke Spine Blue. And basically that allows me to see the herniations and the annular tear. Shot. Come on, Monica. I'm looking up here. Pay attention. Okay. Now, Monica, can I give you some advice? You need to be calling Siemens and asking them how to get rid of that. Do you have somebody's phone number?
I do.
Okay. I would strongly recommend you get them on the phone and ask them how to get rid of the cross that's blocking your surgeon's ability to see what he's doing. All right. Let's go with number 11. We're going to make an incision. Now, we're fixing 3 discs. This patient travels to us from Washington to Florida to the Duke Spine Institute. She's here with her family, and she was told by a surgeon in Washington that she needed a fusion. Fusions, of course, are highly invasive, and she didn't want a fusion. She found the Duke laser disc repair, which is the very best surgery in the world for a disc problem, and she came to Florida for this surgery. You can see I'm placing the dilator. Ariana, would she be in the way if she was over there? Huh? Yeah, go behind Monica and come on over here so you can see what we're doing. Okay. My daughter is here today, so I'm blessed with her presence. She's observing. Shot. Now, Annie, you see the x-ray? See the dilator there? Looks like a pencil right at the front of the disc. Let's get an AP view. So you want to check the position of this on two views, front, back, and side to side. On the side to side, you want to line it up with the disc. On the front back, you want it to be in the middle of the spine. If you're too far to the side, you can go in the wrong place. Shot? All right, it looks good. And the X is exactly where we want it to look. Monica, it's some kind of a tracking thing. Are you on with tech support?
He's gonna call me right back.
Thanks. All right, lateral. One thing to notice is that AP view, you can actually see the esophagus and trachea because they have an esophageal temperature probe, and a trachea has the endotracheal tube. You can see that they're deflected to the side, which is what we want. Shot? Boy, she's relaxed still?
Yes.
It's pretty collapsed disc here. Shot? Mm-hmm. Oh, it's making a difference. So my anesthesiologist is giving me some inline traction on the head, which means he's pulling on the neck. He's pulling the head like that so it opens up the disc space just a fraction. That's perfect. So you can see the tip of the dilator is at the back of the disc. Everybody see that? Show us that. So how did you get rid of the X now?
It just disappeared. I don't know. And I have
Oh my God, you're amazing. Put the arrow right on the tip of the dilator. That is the back of the disc, folks. Okay? Yep, nice job. So now we're going to bring... Oh yeah, but we got to bring this. Now we're going to bring the tube down. Now look at the x-ray now, shot. You see the tube? Show us the tip of the tube. Okay? There's the tip of the tube. It's at the front of the disc. I'm going to bring the tube through the disc, and this is where I need my anesthesiologist and my shoulder puller to give me the best distraction. We call it distraction when you pull apart something, you're distracting it. Shot? Now you want to keep an eye on the tip of the dilator and make sure it doesn't move in. If the dilator moves in, it'll hit the spinal cord and paralyze the patient. So you got to keep an eye on that dilator as you're moving the tube in. And the reason it's so hard to get this tube in is this patient has a very collapsed disc. All right, I'm going to try to wiggle it a little bit to create a little bit of room. Ready, guys? And give me some distraction. Shot. Yeah. Shot. That does not want to go. Shot. There we go. Got a little. Oh, yeah.
Sarah, you open the irrigation?
Man, huh, Louise? Look at that. Thanks, everybody. Good job. Woo! Okay. I do have to ask, this room is warm. Why is the room so warm?
Supposed to be 66. Thank you.
It may be the humidity. How are we doing on are we max cool?
No,
I think we should try to cool it a little more if you can. Yeah. Because you're sweating too, right? And I hate to see you sweat. I haven't even given you a hard time yet. You're sweating already. All right, so new tube.
yeah, no too.
Let's see how it holds up. And wow, fuck yes. Nice job. All right, well, let's see. Oh God, that's beautiful.
I know. Very
Oh,
good people.
maybe
very
actually better than what we had
very
before.
good people.
Okay, very good. So for those of you who have never seen laser surgery, this is the endoscope that we do the laser surgery through. And the endoscope is a long tube that has a hollow space where I can put my instruments, and you can see the laser right there. The laser is the blue fiber. This is a 0.5 millimeter fiber. This is the light source on. You can see the light, and that goes through the endoscope, and it's transmitted by fiber optics to the end. And then you have a camera, so we can see it on the television. So that's what I do all day. I watch TV, and I make a living off of it, right? Get paid for it. All right, we've got irrigation here. which cleans out the blood that's at the bottom and the pieces of herniation. All right, let's go down, down. There it is. So we are at the back of the disc, right where the degeneration is, right where the herniation is. And you see all that red? That's inflammation. Okay, this patient has arthritis. Arthritis means inflammation of a joint. Itis means inflammation. Arth means joint. Arthritis is inflammation of a joint. Okay, so if you've ever heard of arthritis or know somebody with arthritis of the hip, the knee, the shoulder, the spine, this is it right here. You're seeing inside an arthritis joint. And all this white stuff here is abnormal scar tissue and junk. Bone spurs right here. So we're getting rid of the bone spurs with the laser right there. People ask me all the time, Dr. Duke, can the laser get rid of bone spurs? Well, the laser can cut through steel. And of course it can get rid of bone spurs. Now, does that mean we're going to get rid of all your bone spurs? No. We only get rid of the bone spurs that need to be getting rid of. Most bone spurs you don't need to get rid of because they're not causing problems. But some bone spurs do. And we're going to get rid of the ones that are pinching on the nerves. So you can see the laser fiber at 12 o'clock. It's 0.5 millimeter, very skinny, and it's glass. It's made out of glass, and it transmits the laser energy. If you were in the operating room right now, like Ariana is, you could actually see the laser machine. And Oscar is controlling the laser machine right now. The laser machine produces energy. Laser energy is invisible. You can't see it with your eyes. You figure it out? What was it?
He's gonna call apps.
Huh?
He's gonna call apps because he asked if the laser was on and it was not, so he's gonna call apps.
If the laser was on? But what does the laser have anything to do with the fluoro? It doesn't have anything to do with the fluoro.
The laser
Oh, for the fluoro laser. Oh, okay. Interesting. Well, what about Jordan? You may want to check with Jordan. Jordan may know. You have to bother him on his vacation. Huh? Yeah, send him a text. All right, so you can see the inside of the tube. You guys see those dark areas right there? That's from the laser hitting the steel of the tube, and it actually melts the steel. That's how powerful. These are bone spurs right here. That's how powerful the laser is. Yeah, lasers can take out bone spurs, no problem. Like I said, you just don't want to take all the bone spurs because there's no reason to. We're not here to remove bone spurs. We're here to remove pain. She has pain, and we want to get rid of her pain, right? And we want to do it. You got to hold the chest back. You want to do it without doing a fusion. Yeah. All right. Any questions from our audience, Henry?
No current questions, but we do have a couple comments to prioritize. This first one comes from B3 on YouTube. And they said, "Good morning, Doc. I currently had my MRI sent over, still waiting to get a schedule with you. I have an L3-4 and L4-5 disc bulge, and MRI February this year diagnosed with mild lumbar spondylitis." Spondylolisthesis. The pain I'm in is sure not mild, as I've been in pain for 3 to 4 years now. The last 4 months have been really painful, and all postures unbearable.
Understood. E3, YouTube, thank you for sharing. So the reason we haven't gotten back to you, Sam, who does our MRI review, she's out. She will get back to you, and we will get you scheduled. Don't worry. If you don't, just send me another notification next week, and we'll take care of it. But as far as your spondylolisthesis in your lower back, it doesn't matter how big the herniation is. I've seen the tiniest herniations cause massive pain. So that's why I tell everybody, MRIs don't tell you where pain comes from. A good doctor does. And that's what I do. I could tell you exactly where your pain's coming from. But what I can assure you is 2 things. Number 1, your pain is legitimate, and it's coming from your spine. It's either the disc or the facet or both, and I will figure it out with the MRI review. The second thing I can tell you is we can cure your pain, all right, whatever it is. I've not met a single patient that I couldn't cure their pain, okay? And it's just a matter of what treatment we have to do. Thank you for sharing, And I'm going to run a video right now with Henry that's going to show you why do small disc herniations, why do they cause so much pain? And the answer you'll see in the video is inflammation. Same reason this patient has pain, inflammation.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. And now you can see why do people with small disc herniations have big pain. It really has to do with inflammation. It has nothing to do with the size of the herniation. It has to do with the annular tear. Look at all these herniations I'm taking out. All these little pieces right here floating out through the tube. Okay? That's what we do with the Duke laser disc repair. We use the laser to break up the herniation right there into small pieces and release them from the annulus. This is called an annular debridement. And I am removing all the herniation with the laser right there. You see that? Beautiful. And what's left back here is the posterior ligament, which is supposed to be there. Okay, and just behind that is the spinal cord. But look at all the scar tissue, the white stuff I'm removing. That's a bone spur right there. See how easy the laser removes bone spurs? Bam, gone. Seconds. All right, what other questions do we have?
No current questions, but the next comments come from Canes25 on YouTube.
Welcome to our broadcast. Nice to have you back.
They said, "Good morning, good sir. Glad to see you back at your craft. And don't worry, Monica, he is a superhero. He has X-ray vision."
Yes, you're right. Thank you. I should have you come and run my practice because you're very nice. And I am not so nice when things don't go well. As surgeons, we get nasty when things don't go right because we don't like to introduce new things. Surgery is supposed to be the same thing over and over again, very controlled. That way, we don't have to deviate or think. We just do our surgery the way it's supposed to be. But when you start to bring in other challenges during the surgery, then now we're distracted. I can no longer focus on the surgery. I got to focus on other things. So it takes away my attention from the work. And of course, my staff already know that I don't like that. So when they make things happen that distract me from my surgery, they know how I'm going to react, and it's not good. So the best surgery for me is a surgery where everything happens the same way that it's supposed to happen without any kind of deviation. And that's the best way for all surgeons, by the way. All surgeons want the same thing. We want a uncomplicated surgery. And so sometimes the patients make it complicated for us because they have a fat neck or a short neck or a big chest. But when our staff make it complicated for us, that's when we get upset. It's okay for the patient to make it complicated because it's not their fault. There's nothing they can do about it. But I don't want my staff making it complicated for me. So I am a bit demanding, but I think it's justified. All right, just about done with this disc in 10 seconds. We are done. And we're going to go ahead and bring the fluoro back in. And we're going to clean this out with some antibiotics. Let me just see. One more look. One more peek to the left side. By the way, if you've noticed, I've swept from side to side, left to right, on the back of this disc. And you guys see that curve right there? That curve is called the uncinate process.
No. Not yet.
Yeah, just a few seconds. Almost done. There we go. We're done. Great job, everyone. That's one disc down, 2 more to go. Okay, so at this point, I'm done with the DLDR. I'm going to put some antibiotics called betadine. This was developed by NASA to kill bacteria. We don't want any bacteria down here. Okay, we don't want an infection. We've never had an infection in the cervical spine. We've had one infection in the lumbar in 16 years. So I want to keep it so we don't get infections. To do that, we give IV antibiotics in their vein, plus we give the betadine, plus we use Duraprep and Ioband. We use sterile technique. Everything is sterile, been sterilized by a sterilizer, so it kills all the bacteria and funguses. All right, we're done with 1. We're moving on to number 2.
Can we go up?
Huh?
Can we go up?
Go up. You want to go up? No.
No? Are you sure?
No, we're going down. We're going to do the hard one.
All right.
We're going to go to the hardest one next. She's still really relaxed, right? All right, so folks, one of my secrets to doing this surgery is to relax the patient's muscles.
Yeah.
If I were to take my fingers and put it on your neck and push down to your spine, what's going to happen is all your muscles in your throat are going to tighten up. It's called a gag reflex, right, Dr. Berndes? The gag reflex. Let's go, Monica. Shake and bake. So the gag reflex is when something is pressing on your throat and you gag. Now, if she had a gag reflex right now, I wouldn't be able to do the surgery safely. And the Koreans who taught me to do this surgery, they don't put the patients to sleep. And they have gag reflex, and that's how they paralyzed a few patients. Okay? What? Are you all the way down? I would say the table, if anything, needs to go up, but I think I'm okay. Yeah. I mean, you want to bring the table up 1/2 inch? Let's get ready on traction. Good. Shot. That looks good. All right, so folks, we need to go down 1 disc. Let me just count. 2. Show us 2. So number 2 bone in the neck is the tall one, and you always start with that one. Show us the tall part. Up higher. Well, you really need to get some glasses. Up, 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 up. That's C2, right? It goes up and down. Then C3 is the first normal vertebrae, and then 4, then 5, and then 6. So we did 5, 6. We're going to go down and do 6, 7. All right. Everybody ready? I need everybody in position. Okay? I need inline traction. I need a shoulder pull. Let's go ahead. Wait.
Is that,
Did that go through?
no. Is that?
You're 100% sure. All right, so we need to move this, okay? This needs to be moved. Yeah, you should never be pushing against that. Don't worry about that. All right, I need a shoulder pull. I need inline traction and shot. Yeah, there we go. That's beautiful, guys. All right, relax just a little bit. Relax. I'm going to get the tube out, okay? All right, shot. Look how easy the tube came out, huh? Now that we got rid of all the scar tissue in the back of the disc. All right, so what do you think about leaving the tube and just moving the tube plus dilator? We've done it before. Yeah, let's try it. All right, everybody ready? I'm coming out. Shot. So this is the part that I literally had to develop myself, because nobody in the world does 2 discs with the endoscope in the cervical spine. I was the first to do it. So what I do is I'm out, okay? And now I'm going to move down to the next disc. So I need to get an AP. Why do I need an AP? I got to make sure I didn't move to the side. Because if you move to the side, it'd be very bad. So if I did move to the side, I need to correct it now before I go any further. Shot. It's a quick AP. All right, perfect. You can see I'm still in the middle. You can see the spinous process. All right, now I'm going to go down south. I'm going to move down to the next disc with my contraption. And shot. Very good. Here we come. I'm feeling. Got to feel. Oh, mama. And we're coming south. I feel a bone spur. Shot. Yeah, we're right there. Just so close. Shot. I need a little better pull from you guys. Shot. I think we're just on the lip. We are. There it is. Shot. I'm over the hump. I'm right on the disc. I need to make sure I'm in the middle. I feel like I'm sliding. Give me an AP. Give me a coker. Everyone stay. Nobody move. We're almost done. Don't take a shot yet. And shot. All right. So I slid to... No. Stay there. I slid a little bit to the patient's left. And shot. All right. I've corrected. Now I'm back in the middle. Are you? And you see the middle? You see the spinous process, little circles behind on the bone, above and below? That means I'm in the middle. Okay? This is the hardest part of the surgery. And shot. Oh, okay. So that was a beautiful shot. All right, so I slid down the bone spur, shot. Now I'm back where I need to be. That feels good. So I'm going to drive this in with the mallet. Everyone stay where you are. Oh yeah, baby. Right there, shot. Yes. Now let's double check AP once more just to make sure we haven't moved to the side. It's very important when you enter the disc, you enter as close to the middle as you can. You're allowed to be to the side 1 centimeter, 10 millimeters each way. No problem. Perfect. We're right in the middle. Back to a lateral. Great job. Stay there, everybody. Do not release. I'm almost done. Perfect. All right, you guys ready? Here we go. Shot. Nice, huh? We didn't even have to take the tube out. Give me in line. Shot. Perfect.
Disco, no?
What? Disco? Disco. Yeah, of course. How could I not do disco? Who loves Adam Sandler's movie? Huh? All right, everyone relax for a second. You know what I'm talking about? Berndes? The Zohan, right? Don't mess with the Zohan. A little disco. One of my favorite movies. Shot. All right. Let's do a discogram. We're going to inject some dye into that little tube. Remember, the dye has two parts. It's got the omnipaque, so we can see it with the x-ray. And then it's got the Duke Spine blue dye, which is indigo carmine, which is very hard to get a hold of, by the way. You wouldn't believe what we have to go to get it. All right, let's go lateral. Give me a shoulder pull. 2, 3, 4, 5, 6, 7. Ariana, you're going to have to leave. It's 10:30. Shot. I can't see the back of that dilator. I need to see the back of the dilator. Just a little bit more, guys. Go. A little more, go. All right, so I'm almost there. Yeah, that's beautiful. Shot. Okay, I don't want to go past the back of the disc. Whoops. Yeah, that's it. Right there. Perfect. Now stay. Nobody move. I'm going to have to hammer in the tube.
I think you need to remove the thing. Hey.
The what? Oh.
Yeah.
You're right. So I was saving time, but I still have to take that off. Thank you. Okay, everybody ready? All right, we got an inline traction shot. I need a little better than that. Shot. Oh yeah. Shot. 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 Stay where you are, people. Okay, so this is super tight again. Now, people ask me, Dr. Duke, what about a degenerated disc? Can you fix that? Well, we just did. That was the other disc we did. This one is equally degenerated. We should create an impactor here that doesn't have a cutting surface. Shot. Nice, guys. Stay there. Shot. A little more. Shot. Shot. Oh my. Shot. Berndes, are you giving me everything you can? Shot. Shot. It's not even moving, huh? Yeah. Shot. All right, I just loosen it up a little. Let's see if that works. But you guys are giving me your absolute best, huh? Fucking hell. Oh, that's a beautiful shot. I cannot get in. Nope. Let's look at the MRI real quick. Everyone relax. I need the MRI up. So when do we decide not to bring MRIs up, guys? That vial right there, we're not using anymore, right? Yeah. Yeah, just for this case. All right, so we're on a holding pattern. Henry, why don't you show the audience how does the Duke laser disc repair actually work?
Playing.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. It's going to affect the dilator? No. How? No, not diameter, but like this at the end, tapered. Yeah, because this, we've Jimmy rigged this. This is not designed for this. All right. Yeah, yeah, normally we don't have that problem. All right, we're just taking a peek at the MRI. 2, 3, 4, 5. Yeah, 5, 6 is the worst. We'd fix that one. Keep going, keep going, keep going. Scroll, scroll. Other way. Keep going. Yep, now go back again. Other way. Yep, all right. We're going to move up to 4, 5. So I think I'm going to take the tube out, right?
Would you like to try one more time? Or
No. No, I mean any more and I'm going to break the equipment. I've done everything we can do. And honestly, of the 3 discs, thank God this is the least affected. Amazing. It's moving. Yeah. All right, everybody ready? So I want to get everybody in position. Yeah, you guys don't have to pull. I just want to get this out, which will take me a second. Shot. And then now I'm going to take the tube up and I'm going to move the dilator south. All right. Now I am going to need to see the dilator. at some point I will need to see, guys. So let's get a shot. All right, good. That's it right there?
Yes, sir.
So we're going to come up a little further. Almost out. There we go. Shot. All right, now I'm going to move up the spine, past the bone spurs, and slide up, shot, up to, let's get an AP. Slide up to 4-5, which is the top disc. So far, good. We're just not going to be able to do 6-7. We were in there, but we couldn't advance the tube. The disc is too collapsed. Okay, your APs are terrible, by the way. You got to center the tip, and you should have the spine more centered. It's going off to the side there. All right, it feels like I just went back into 5-6. Yep, right? 2, 3, 4, 5, 6. And now we're going to come up and go to 4-5. There we go. We're outside. Again, I want to make sure I'm in the middle. AP. Everyone good? We don't need a shoulder pull at this point. And shot. Give me a true AP. All right, so I'm a little off to her left. I'm going to correct that. Shot. Should be corrected. There we go. And I'll correct a little bit more, another millimeter. So go ahead and go lateral. Folks, when it comes to spine surgery, you want to try to be perfect. You're never going to be perfect as a human being. Obviously, we can't be perfect, but we're going to try to get as close as possible every time. And if you aim for perfection, you might score a 99, which is damn good. Good enough for government work, as they say. Shot. Okay, I want another AP. I want to make sure before I start pounding this thing in to the disc, I want to verify that I'm in the middle. So far, she's doing fantastic. 2, 3, 4, 5. All right, beautiful. You can see, by the way, show us the esophageal probe. Show us the endotracheal tube. Can you do that, Monica? Yeah, that's fine. Thank you. On that view, show us the endotracheal tube. It's a solid line on the AP view. Henry, go to that X-ray view that she just posted. All right, so there's the endotracheal tube, and show us the esophagus temperature probe. It's braided. That's it right there. Good. And so these two tubes are in the two luminous structures. Shot. The trachea and esophagus. And you want to make sure that they're deviated. You're not going through them. You're going around them. And that's part of the trick of what I do is get around them. I have to move them to the side initially before I place my needle. A lot of neurosurgeons don't understand this shot. They've never done this surgery in their life. It scares the bejesus out of them because we're typically afraid of things we don't know. Shot. Shot. I'm trying to inject a little dye, and there it goes. Show us the tear, and show us the dye in the epidural space behind the herniation. Very good. There's the tear, the little black line, and there's the dye. All right, give me a shot. 2, 3, 4, 5. Perfect. Shot. All right, perfect. We're done. Let's get the tube in. So I don't expect any problems putting this tube in because 4-5 is not a collapsed disc. It's not degenerated very much at all. It's just herniated. But 6-7, that was just impossible. We tried. I was hammering as hard as I felt safe. Couldn't get it. Shot. But honestly, I think we're going to achieve virtually every goal we had with the surgery. Because a disc that you can't get in like that is basically fused itself, so it's not causing symptoms. You don't know that. It's not fused per se, like on a CAT scan you wouldn't see fusion, but the fact that it can't move at all tells me it's not moving, therefore it's not contributing to her shot. All right, questions from our audience?
We have a couple questions and a couple comments.
Shot.
This first one comes from Danette on Facebook.
Shot. All right, at this point, we're at the back of the disc, and we're going to start our last disc. We'll be done in 15 minutes. Yes, Danette, I'm happy to take your question.
She said, I am
Scope on.
having an EMG today and tomorrow. I've been in a lot of pain since I have 11 years of inflammation and pain. I have submitted my MRI yesterday, so I can't wait to get a consultation with you. This will be my first EMG. My pain management only gave me nerve blocks and epidural for years until I couldn't walk last year and we had to have surgery on my back. Will I be in a lot of pain after the EMG?
So Danette, will you be in a lot of pain after the EMG? So the answer is no. The EMGs can be a little bit uncomfortable for patients because after all, they're going to stick little needles in you and they're going to zap your muscles and make them, zap your nerves and make them, it's going to be uncomfortable, the EMG. Laser. No, I'm hitting the pedal. It's not coming on. Oh, weird. Maybe it's this tube right here. Can we move that? Those should never be where my feet are. Okay, so the EMG itself can be uncomfortable, but you won't be in pain after the EMG. I mean, you'll be in the usual pain that you're in from your disc or your facet, but you will not be in pain per se from the procedure itself. It's a diagnostic test. We use EMGs often because EMGs don't tell you about what causes pain. Just so you understand that, EMG never tells you about what causes your pain. An EMG looks for nerve root damage or peripheral nerve damage, and peripheral nerve damage doesn't cause pain. Peripheral nerve damage causes weakness, numbness, tingling. Inflammation causes pain, and that's what most doctors don't understand. So the nerve test is a great idea, but it's not going to tell you why you're having pain. And no doctor should ever tell you it does, because it won't. The way you figure out why you're having pain is you meet with me. And literally, I'm one of the few in the world that can tell you why you're having pain. Most doctors do not know what causes back pain or neck pain, and they'll tell you, we don't know. Look at all those herniations coming out. Did you guys see that? They floated out from the back of this disc, right where the spinal cord is. We'll go over that in a little bit. You'll see it better in just a minute. But see the crack down there, right below the laser, right there? That's where the spinal cord is, and those herniations came out of there. If you rewind a little bit, you'll see. They literally floated out of that crack. All right, so what causes back pain, what causes leg pain is inflammation. The only question is, where is the inflammation coming from? And, wow, another herniation. Look at that. So many pieces of herniation coming out. The inflammation can either be happening from a disc, from the tear in the back of the disc like this one, or it could be coming from your facet joints. Now, which is more common for back pain? The disc is more common. The disc is the cause of back pain in 90% of the time. The facet joints are the cause of back pain about 10%. These are rough numbers. The SI joint, maybe 5%, and the piriformis muscle, I really don't consider the piriformis causing back pain, but the piriformis is another cause of back pain. Lower back pain, like buttock pain. But strictly back pain, it's 90% disc, and it's 10% facet. But if you go below the belt line, below the butt crack, then you're talking about, my God, look at all the herniations. You're talking about piriformis and sacroiliac joint, and sometimes coccyx. So coccydynia, which is inflammation of the coccygeal ligament, can also give you kind of like pain down by your buttock area, okay? So the key is, I'm telling you right now, you will never be treated properly by your doctors. You're always going to be in pain unless you get the right diagnosis. And then, when you get the right diagnosis, Now you've gotten half of it done. Now you need the right treatment. And your pain management doctor cannot give you the right treatment, because the right treatment is a curative treatment, and it's the Duke laser disc repair. And they don't know how to do that procedure, okay? The only people that do it are at Duke Spine Institute. And I haven't taught your pain management doctor how to do it. So your best option, I hate to tell you this, is to, but it's true, at this point in time in 2023, you need to contact Duke Spine, get your MRI to me. I'll review it with you. I'll show you exactly why you're having pain, and then we'll give you a recommended treatment. And I even will answer all your questions for you during the Zoom meeting. And by the way, if that's not enough, it's all free. We don't charge you. Someday we may have to start charging, but not today. Today we offer this free as a service to the community. And when I say community, I mean international community, because our patients are international. They come from all over the world. Look at the tear right there and the herniation. Those fibers that running left to right, it's a little bit overexposed on the camera. If we can turn the light down just a titch, you can see the herniation right here. I'm zapping it out. It's literally sitting on top of the spinal cord.
No.
Yeah.
3 times. That's it.
Yeah, oh, that's better. So now everything isn't just a white blur. I would go up one, just take it down, take it up one. And there we're getting all the, see the crack? You guys see the tear in the annulus from here to here? That's about now remember, my laser fiber is 0.5 millimeter. That's a 1 millimeter tear. So it's tiny. And that's herniation. And look at it, it's golden, right? What do we know about gold? Gold color, when the laser hits tissue, means calcium. That means it's this damaged tissue. And that's called dystrophic calcification. Dystrophic calcification. All right. So we are at the back of the disc at C4-5, literally on top of the spinal cord. And that's why this surgery is so delicate, because you need to understand the anatomy. You need to be basically a neurosurgeon to do this kind of surgery. You cannot do it as an orthopedic, cannot do it as a pain management. There's no doctor in the world that can do this besides, in my opinion, a neurosurgeon, okay? And I happen to be a neurosurgeon, thank God. Now, when I was becoming a neurosurgeon, did I expect to be doing this? Of course not, because I'm the one who pioneered the surgery. And I didn't do it until later in my career, until I was finished training, until I had done 1,000 fusions. And I realized there's got to be a better way. Look at all these herniations coming out. Okay, so by going to the back of the disc where the painful part of the herniation is and cleaning it up, this is all scar tissue, with the laser, it's called the Duke laser disc repair. We pioneered it here at Duke Spine. We're the first to do it, the first to publish it. By doing this, we're able to get rid of her neck pain. And we're getting rid of her arm symptoms because we're treating the radiculopathy, which is the pinched nerve. Okay, and that's what you find on a nerve test. Like our viewer asked us about a nerve test. Look at that scar tissue. Look how the laser hits it and it contracts. You guys see that? How it's contracting and tightening the scar tissue. It's like moving downwards to the right, which is downwards. All right, here's the foramen, the neuroforamen over here. And look at that herniation in the foramen right there. You guys see that? It's sitting on the nerve root. And we're going to get rid of it right now. And a little bit of bone spur. So once I do this, I got 5 minutes left, and we're done. I'm letting my anesthesiologist know. This is the neuroforamen on the left at C4-5. You can see the nerve root right there. You guys see the nerve root right here? Bam, that's the nerve root. We're bouncing on it. Amazing how good the visibility is, isn't it? You have the right equipment. You have the right procedure. Now notice there's no blood. Why? Because this is a bloodless surgery, okay? And the Duke laser disc repair is bloodless. The disc itself doesn't have much blood, and we're not making it bleed with the surgery because we're not creating trauma. So because there's no bleeding, there's no scar tissue, okay? Just about done, 30 seconds, and we'll be done. Oh, look at that. Ooh, it's beautiful. This is revolutionary, folks. You guys are seeing history, spine surgery history in the making. Literally. I mean, we're the first to do it. We're the only ones currently doing it in the world. And we're going to keep doing it because people want it. They don't want to be fused anymore. They don't want metal in their neck. I don't blame them. They shouldn't have metal. Metal is bad. We're going to put the metal companies out of business together. All right? They don't want to go out of business. They want your money. They want the billions of dollars in profit they're making every year. Oh, look at that. Oh, God, it's beautiful. That's all scar tissue from inflammation. So tiny little tear. You guys saw that tear, right? If you look at the MRI on this patient, 95% of spine surgeons would not be operating on this disc because they don't see a big herniation. I didn't see a big herniation, but I saw a tear and I saw her pain was coming from this area, so I knew this was painful for her. Look at all that scar tissue, that white wall of scar tissue. That's from the herniation causing inflammation. She's been having it for, this is like 20 years of inflammation, easy. Oh, another herniation coming out. So by the way, did I say she's from Washington? She's from Washington, right? Everybody? Huh?
I'm sorry, she's from Florida.
Oh, she's Florida. I apologize. She's Florida. I'm thinking of a different, oh, you guys see that herniation come out? I'm thinking of, I think, one of our next patients from Washington. From all over the place. All right, I think that should be it. That was a nice chunk of herniation. And I don't see, maybe a little bit there. I don't really see much else. Just float that out.
Next patient is from Louisiana.
Louisiana is the next one. So maybe it's the last one I'm thinking of. All right, we're done.
Lights on, please. Thank you.
So type up your questions and I'll come answer them for you face to face. But we're done. Watch the laser. Good job, everybody. A little bit of antibiotics, betadine, developed by NASA. NASA, by the way, is just 15 minutes away from Duke Spine Institute. We actually get a fair amount of people from NASA coming here for treatment. And if I can tell you this, if Elon Musk is fighting Mark Zuckerberg in a cage fight, Elon Musk will be visiting us too for his neck.
Mama said no.
Huh?
I thought his mama said no.
Elon Musk, mom.
His mom said no fight with Zuckerberg?
Yeah.
That's going to be the biggest ticket, like, for the next 20 years.
He's been training regardless of what mom said.
Is that right?
Zuckerberg training?
Oh, Zuckerberg's been training anyway.
He's like literally training besides what the mom saying now.
Who do you put your money on?
Honestly, Elon Musk. 'cause he
Musk?
has the height, yeah. And he has longer
He has
arms.
longer arms. And he's also bigger bone.
He's done jiu-jitsu.
Come on,
and
guys.
everything before.
Jiu-jitsu, whoever does Brazilian Jiu-Jitsu is going to win. I mean, if they're good, whoever does it the best is going to win.
I concur.
Yeah. I mean, it doesn't matter how big you are. What matters is technique. Here you go. Hold that. All right. Let me show you guys. Henry, let's take a look at the incision. I want everybody to see just how small this is. It's a 4 millimeter incision. Okay. You guys see it?
Yes, we do.
I made it 5 millimeters today, so I was a millimeter longer than usual. So a 4 or 5 millimeter skin incision for the whole surgery. No metal, no fusion, no artificial disc needed. This is the next level in treating disc problems in the spine. And it doesn't matter if it's a herniated disc, a bulging disc, a degenerated disc. If it's causing pain, this is the procedure you want. By the way, she's going to go home in an hour. The recovery is literally 1 hour home. We're not at a hospital. This is outpatient surgery. We're doing it at our surgery center here in Florida. It's safe. That's how safe the procedure is. We've never had a complication with the cervical. We had one lumbar infection, and that's it. That's over 1,600 surgeries, 16 years. All right, blood loss, I'm going to call 1.5 mil. Type your questions up. I'll come answer them for you. And Henry, you want to show our audience a nice result for one of our patients? It is February 23rd, 2022, and I'm here with one of my patients who's traveled from Kansas. Is that correct?
That's correct, Wichita, Kansas.
Wichita, Kansas, and clearly you've had surgery. We just did it less than 24 hours ago. You've got your incision there on your neck. How are you feeling today?
Much better. Much better. 26 years ago, I had a fusion of C6 and C7. They told me in Wichita that I would need to have fusions of C4 and 5 and C5 and 6. They set up the surgery for the 23rd March. And I'm going, I can't wait that long. This thing hurts, it's killing me, I cannot sleep, and so on. My husband Dale did a whole batch of research online, and he says, I want you to be able to move your neck after surgery.
Yes.
And
I did a
he
lot
did
of
a
Googling.
lot of research, and we found Dr. Duke to be a man of integrity. He films all of his surgeries, he puts many of them online, and you can see for yourself all the good work that he's doing, and that he really likes to help people. What he does is generally not covered by Medicare and not covered by some other insurances, but it very well should be, because it really helps people.
So what was life like for you before surgery?
My pain was mostly in the neck and shooting down my shoulder, and especially in my shoulder.
And you had really bad weakness with your arm. You couldn't even lift your arm, right?
That's
before
correct.
surgery?
That's correct.
Show us what you can do now.
Before surgery, I could lift it to about here, and now I can lift it.
All the
Yeah,
way up.
just the next day, right
You couldn't
after.
do that before.
Yeah, that's because she had a herniated disc, two of them, C4-5, C5-6, and the herniations were literally sitting on the nerve. And we got in there, and if you watch this video segment right here, you can actually see there's the laser, and as we're removing the herniation, it literally pops right out of the foramen where it was sitting on top of the nerve, crushing the nerve. So, and the surgery was a success. We lost almost no blood at all, and you can see your incision is tiny, and here you are one day after surgery. It was outpatient, and you're ready to go home, right? You guys flying
Going
back
home tomorrow.
tomorrow? Okay, very good.
Try and enjoy a little bit of Florida today before we go back to the snow.
Okay, it is snowing there, huh, in Kansas?
Probably.
Okay.
If not today, then tomorrow.
Well, stay another week.
And yesterday it was 70
I
degrees
wish.
there.
70 degrees where, in Kansas?
Or maybe that was the day before it was 70 degrees,
nice.
and then they woke up to about 11 degrees.
Ah, so the cold front came in. We get those from time to time, and it gets cold around 60 degrees. Well, most of the time it's very pretty here in Florida. Well, we're glad you're here. Is there anything else you want to say to the world about herniated discs in the neck and surgery?
Dr. Duke will give you a free look-see on the MRI. It's well worth your time. And he will do a Zoom call with you and tell you what he can do for you. So go for it.
I said that it was so important that I said I'd pay for it. You know, because we got a little bit of a nest egg, and sure it's going to cost a little bit, but it was worth it because we got results. I mean, that's amazing.
Your health is the most important thing in the world, people's health. So
You can't take it with you when you
yeah.
pass away.
All right, folks, we'll have a safe travels back.
Thank
Great
you.
to see you. Glad we can help you out. That's a nice.
Thank you.
That's a nice shake. Good morning, I'm Dr. Ara Duke-Majan, CEO and founder of the Duke Spine Institute, here with one of my patients who traveled from Mississippi,
Yes, sir. Oxford, Mississippi.
Oxford, Mississippi, which I've never been to Oxford, Mississippi, but I'm sure it's a lovely place.
Very nice.
And why did you come to Duke Spine Institute here in Florida?
I'm having issues with my lower back, shooting a pain all the way down towards my elbow, as well as having a little bit of stumbling while I'm walking within my left leg. And went to other physicians to look at my spine, whatever, and they wanted to do fusion and all kinds of other nonsense that I thought maybe there might be a simpler way, a process of doing things. Did a lot of research and found Dr. Duke here.
And what do we do for you?
And Dr.
Dr. Duke Majan here with you. I was just in the operating room and now I'm here in the conference room and broadcast room with Henry. So our patient is Floridian, which I thought she was from out of state, but she came to us because she was having really bad neck pain and pain in her weakness in her arm, numbness in her arms, and pain going into her shoulder. She does also have a shoulder problem, which we talked about yesterday. She'll get that treated. But today we had 3 discs we wanted to repair, and we had the facet joints. And just so people understand the difference, okay, look at the spine here. This is a cervical spine. This is the anterior longitudinal ligament. The discs are right behind the ALL. You know, if this is the front, the discs are right here. You can see them. So to get into the disc, I had to go through the ALL, and I went through the disc to the back. And that's where I did my magic, was back there, you know, with the laser. Now, before we did that, we had to do a plasma rhizotomy because she actually had pain also coming from these facet joints in the back of the spine. Not the disc just, but also the facet joints. They had arthritis in them. So I went through the back and I actually did a huge burn right where the pain nerve runs that goes to the joints, and I killed that. It's called the Duke plasma rhizotomy. We do it for facet joint pain. Most doctors do an RFA. RFAs don't last and they don't work. They don't work, they don't last. So 2 good reasons not to do them. And patients keep coming back and getting more RFAs to the doctor. The doctor's just making money, and we want to fix the patient. We don't want them coming back. So we developed a new technology called Duke plasma rhizotomy. It's being patented, and it basically allows us to burn the hell out of the nerve that is the pain nerve in the back of the spine, whether it's cervical, thoracic, or lumbar. It works very well. We've been doing it for over a year now. We've had no complications, and we've had nobody come back with the facet pain afterwards. So we've done over 100 patients at this point. Then we went to the front and we did number 5, 6. I tried to get into 6, 7. I could not. I was hammering the tube as hard as I could safely, and it was not moving. So that disc is so collapsed that, but now that I tried and I couldn't get in, I know it's not moving. That disc is not moving. Therefore, I believe it's not causing any symptoms. So that's good news for the patient. I'm happy because I don't think she's having any problems from that disc. Impossible for me to know that based on the MRI or any other test. So surgery went well for her. We fixed 2 discs out of the 3 we intended, and there were a lot of herniations in those 2 discs. Okay, questions?
Questions. First one comes from Samir on YouTube.
Hello, Samir, on YouTube. Thanks for writing a question.
They asked, I have osteophytes. Is there any way those can be removed by DLDR?
Yes, Samir. Osteophytes are bone spurs, and we can remove them with the DLDR. Absolutely. However, you don't need them removed. Why? Because, folks, let me just be honest with you. I'm always honest with you. I hate to tell you guys things that you don't want to hear. But surgeons, spine surgeons, tell patients you need surgery because you have osteophytes. But they are not telling you the truth. You don't need surgery because you have osteophytes. You need surgery for other reasons. And there are 3 reasons to have surgery. Number 1, you have pain coming from something that needs surgery to fix it, like the disc or facet. Number 2, you have a pinched nerve that's being pinched and causing nerve damage. Number 3, you have a pinched spinal cord. Your spinal cord's being pinched. So, pinched spinal cord, pinched nerve, pain. Those are the 3 reasons to have surgery. There's no other. And of course, we're talking about degenerative problems. We're not talking about trauma. Like if you get into a car accident, you fracture your spine, and your spine is hanging on by a thread, you need surgery because it's unstable. Excuse me, we're not talking about instability. We're talking about 98% of spine surgery is done for degenerative conditions. We're not talking about trauma, fracture dislocations. We're talking about degenerative problems, okay? Not tumor, not infection, not fracture. We're talking about degenerative, which is 98% of spine surgery. So for degenerative conditions like bone spurs never cause symptoms. I have, honest to God, almost never seen a bone spur cause symptoms. I do not recommend just doing surgery for bone spurs, but other spine surgeons like to tell patients, oh, you need surgery, you got bone spurs. And the patients go, oh yeah, I need surgery because I have bone spurs. There's no other way to get rid of bone spurs, right? Because here's what happens. This is the reality, folks. You're the patient. I got pain. You go to the spine surgeon. Spine surgeon looks and says, I want to do surgery because I need to make a payment on my Mercedes. How do I get this patient to believe they need surgery? You have pain. You need surgery. The patient says, hell no, I don't want surgery for pain. I'm going to go for physical therapy. Lost that one. Next patient comes. I've got pain. Oh, you need surgery for pain. Nope, I'm going to go to physical therapy. Another one. Hey doctor, I need surgery. I've got pain. Oh, you got bone spurs in your spine. We have to go and take those out. Oh, physical therapy won't get rid of bone spurs, right? Nope, you need surgery. I'll be there tomorrow. Okay, so it's a psychological game being played on patients by highlighting and pointing out your bone spurs when the bone spurs are not the problem. I take patients who are in pain, I do the laser surgery, I leave 90% of their bone spurs there, and they're out of pain completely. Their arm is better, their weakness is gone, the numbness goes away, their neck pain goes away, but I leave all the bone spurs. Why? Because the bone spurs don't cause symptoms. Doctors tell patients that because they're trying to convince them to have surgery. So stop believing the bullshit. Don't be a victim of nonsense and misinformation.
All right, this is a mini conversation, but a beautiful conversation between Trust on YouTube and B3 on YouTube.
Trust and B3
Yeah.
conversing on our channel. I love it.
Trust said, some do not know how traumatic herniated discs are. It is not just a muscle backache. Besides the physical pain, the mental and emotional pain is just as traumatic. It destroys life, marriages, families. So when you see the testimonials and grown men cry, it is because their life has been given back to them.
Yeah.
Their life given back to them by you, Dr. Duke. B3 commented, couldn't agree more. Trust. I am always in a very...
I want to just stop right there.
Of course, go.
I didn't give them their life back. God gave them their life back. God used me and other parts of God's creation, Henry, other people. We're just tools. That's all we are. God, it's God's purpose. I believe that. And we're just here to help.
Of course. B3 added on to that. I couldn't agree more with that. Trust. I'm always in a very bad mental state. I will argue the emotional pain is even more. For example, I have my wedding coming up and I'm so afraid. Trust added. The best gift you can give yourself and your new wife is to have this surgery. A life of misery of you and and everyone all around you without it. Fight for it. Make it your first goal. Your health is the most valuable. And Trust added, B3 is beautiful that she's standing by you. B3 ending this conversation. Thanks. Yes, she is. She's been so supportive. She has more faith in me.
Yeah. Well, thank you, Trust and B3, for engaging in a conversation. Both of you are correct. Why do you think I do what I do? I do it because, number one, I can fix people. Number two, I do it because people need it. I'm not creating a demand here. It's there. The demand is there. I am the solution. Duke Spine is the solution. Okay, that's why we want you all to see that, because it's real. And people, unfortunately, don't know about us, and they end up living their lives for 10, 20, 30, 40, 50 years in severe pain, and their lives are miserable, and they don't want to live. And there's a lot of people who commit suicide because of the pain. They don't see a way out. We need them to know there is a way out. Now, you may not be able to get it done today. You may not be able to travel to Florida and get it done. But it gives people something to work towards, right? Like when I was I know I want to be a doctor, but you don't say, hey, I want to be a doctor, and then you're a doctor. You have to invest your time, your effort, money. I had to pay for college. I had to pay for med school. I had to borrow so much money, and I had a lot of debt, but I spent college 5 years because I was doing bad in school, med school 4 years, and then residency 7 years. So add that up. That's like, what, 16 years? I had to basically pay for 16 years, sacrifice my entire life for 16 years. No fun, no dating, nothing. Just, I mean, I dated a little bit, but I didn't go out and have fun like everybody else. I was studying all the time. Point is, I sacrificed 16 years of my life to get the knowledge I needed to do what I do. So if I can sacrifice 16 years of my life to achieve a goal, well, people in pain could sacrifice a little bit to put it off, but save and be able to travel here and get their pain taken care of. It's that important, okay? It will improve your quality of life dramatically. It will improve the quality of life of the people around you, your spouses, your children, whoever is reliant on you, people that are empathizing with you and suffering with you mentally, psychologically. I mean, I can't even imagine if my wife had pain all the time. I wouldn't know what to do. I'd be depressed all the time. So I empathize with those people. I feel for them and suffering that they go through. And that's why I'm here, okay? I have plenty of money. I could have retired years ago. My wife and I talk about retirement and me traveling and just having fun. But see, that would defeat my purpose in life. I am here for a reason. And God put me here, and I owe it to God to do my job and take care of people. Why? Because there's nobody else doing it. That's the problem. All these other surgeons are doing other things that don't work and that pay better for them, and I used to do them. I got paid very well. But now they're like just trying to use patients to make money, and they're not really fixing the patient. So I see myself as being literally the only person doing what's right for people. How can I retire at this point, you know? How can I leave those people that are suffering? So I believe I have a purpose. It's to educate people, to teach people about what's available to cure their back and neck pain, okay? And now, like I said, God has opened another door, and we're actually curing knee pain. People with chronic knee pain, we're able to go in there and kill the pain nerves with a minor procedure. It takes 15 minutes. And they literally have a 30-minute recovery, and their knee pain is gone, and they're now walking around like normal people. And that's for people with knee pain arthritis, okay? So I see more things happening. We're going to be doing hips soon. We're going to be doing shoulders soon. I mean, it just doesn't end. There's no end to the amount of help we can do for people. So I'm glad you guys are talking about it. That's what I want. This has to be a grassroots effort. I cannot individually teach everybody. It's impossible. I'm one person. So I need to use avenues of education like social media, YouTube, Twitter, Facebook, LinkedIn, wherever, you know, TikTok, to try to get the word out, okay? And that's what we're trying to do. And I got great people, and I'm building a team, and I've got more people that want to come and help. So the word is spreading, and it's spreading because we have great results for people. That's the only reason. If our results weren't there, we wouldn't be doing this.
And this next one comes from Danette. It is a little pretty long, but it is coming back to the EMG part aspect of it, and she says that she's having it in both legs, and I'm getting her words. I'm getting all of that, and I'm having it in both arms too. When I lay a certain way, will my lower back do that too?
No, Danette, your lower back will not cause arm symptoms. You got a problem in your neck as well.
And she followed up with saying, I was getting that too, where in my buttocks is at and tailbone. I think she said at my tailbone. I am at my breaking point and need help. I sent my MRI yesterday, and following up what you just said, I am that person. Been home and out of work since October, and after my surgery, my kids are 7 and 11, and I can't enjoy them right now because I'm in so much pain at home and depressed.
Danette, I'm so sorry you're suffering. There are millions of people like you, and that's why we're doing what we do. We can fix you. I just need to see your MRI, see you, do an exam, get a little bit of information. I can do it all in about 10 minutes on Zoom and come up with a plan to treat you to fix your back pain. So that was, again, God's gift to me, and I want to share it with the world. But I can't do it by text. I have to actually see you. All right, next.
Next two questions come from Severin on YouTube, and Severin said, first question, is it possible to assess before surgery how much percent of the annulus is inflamed, how much of the annulus can be removed safely, and what percentage of annulus damage, ACDF, is needed?
Great question, Severin. So questions are focused on the annulus, the inflammation in the annulus, how much annulus can be removed. So just so you understand, we're not removing the annulus, we're removing the inflammation and the scar tissue and the herniation. That's what we're removing, and the calcification and the bone spurs when we need to. That's what we're removing. We're not removing the annulus. The annulus is destroyed by the condition. And can you tell how much? There's no way to tell until you go in endoscopically and look at it. The MRI won't show you, the CAT scan won't show you. There is no tool in the world that can tell you how much annulus is destroyed and how much needs to be removed until I go in with the scope and I look and I see. And if you watch enough of my surgeries, you'll see that in some people it's complete destruction of the annulus, it's there. In other people it's very mild, maybe 10%. But there's no way to tell ahead of time. Okay, great question.
Last but not least, from Severin once more on YouTube, asking what kind of physical damage occurs when the surgery for a herniated cervical disc is postponed for years?
What kind of physical damage occurs when you postpone surgery for a herniated disc? Well, you can have nerve damage, and you can have spinal cord damage, and you can have damage to the annulus that gets worse. Think about the annular tear and the herniation and the inflammation as being a fire burning in a woods. There's lots of woods, there's lots of material for the fire to burn. The only way you're going to stop that fire is by putting out the fire. That's what we're doing. We're putting out the inflammation. That's the fire. And by putting it out sooner with the Duke laser disc repair, you're actually saving your annulus. You're saving the forest. You're saving the trees. So the sooner you get the Duke laser disc repair done, the better.
And that is it for questions.
All right, we'll be back in about 30 minutes with our next surgery. It's going to be a lumbar. This patient is having the maximum done. We're going to do bilateral 3-4, bilateral 4-5, and then left 5-1, and then left L3, 4, 4, 5, 5, 1 facet joints. So just to let you guys know, we're going to be operating with the Duke laser disc repair to fix discs that are herniated and annular tears on both sides at 3-4, both sides at 4-5, left side at 5-1, and then I'm going to burn the pain nerve to the joints, the facet joints that are causing pain on the left side at 3-4, 4, 5, 5, 1. So that'll be a great surgery to watch.